This is the lecture over meningitis. This can be found in chapter 36. So what is happening in the body? There's an inflammation of the brain and spinal cord meninges, which is usually from infection, and it can involve the inflammation of all three meningeal membranes, the dura mater, the arachnoid, and the pia mater. Infection of the meninges of the brain and spinal cord due to viruses, bacteria, fungus, and protozoa. The signs and symptoms are similar with each infectious sources. Organisms responsible enter the central nervous system via the bloodstream or directly introduced to the central nervous system, such as from a penetrating trauma or surgical procedure. Assessment findings. You'll find some key features found on box 3611 on page 908 in your book. This includes decreased level of consciousness, disorientation, pupil reaction and eye movement such as photophobia and nystagmus, motor responses such as hemiparesis, hemiplegia, and decreased muscle tone. The decreased muscle tone is usually found later in the disease process. And then you'll have some cranial nerve dysfunction. Memory changes will also occur such as short attention span, personality, and behavior changes. They'll complain of severe unrelenting headache and generalized muscle aches and pains or myalgia. Nausea, vomiting, fever, chills, and tachycardia may also be present. In meningococcal meningitis, you'll find a red macular rash. Nuchal rigidity, Koenig sign, and Brudzinski sign is traditionally used to diagnose meningitis. However, these findings occur only in a small percentage of patients that have a definitive diagnosis. And then you'll want to refer to signs and symptoms related to increased intracranial pressure and refer to your handout for that. A urine, throat, and nasal culture and sensitivity will be done to identify the organism and to determine appropriate treatment. CBC will be collected and it will reveal an elevated white blood cell count. A lumbar puncture analysis is performed to assess for the appearance of the cerebral spinal fluid. Cloudy means there is a bacterial infection, and clear is usually a viral infection. Elevated white blood cell count, elevated protein, decreased glucose could be indications of bacterial, and then an elevated cerebral spinal fluid pressure. A CT or MRI can be done to identify any intracranial abnormalities, such as an abscess or a tumor. You'll want to refer to page 877 and 878 in your book to read more about the CT and MRI, these neurological diagnostic testings. And then refer to page 878, box 35.3, and these are the precautions that we want to use for contrast for neurologic diagnostic testing. So if someone's going under contrast or having neurologic testing using contrast, your facility may require an informed consent or a separate consent. You want to assess the patient for any allergies to contrast material, iodine, shellfish, things of that nature. Assess their risk for any kidney damage, such as if they have any pre-existing conditions, such as renal disease or chronic kidney disease, diabetic neuropathy, heart failure, dehydration. Their age can be a factor. If they're on any type of medications that interfere with renal perfusion, such as metformin or NSAIDs, and if they've had any contrast media in the past 72 hours. You want to evaluate their kidney functions, and we'll draw serum creatinine and GFR, and then communicate with a primary care physician if there are allergies or risk factors present to see if they do want them to, if it's safe for them to undergo that contrast. Provide adequate hydration before and after contrast administration. We want to flush the contrast out of their system. And then reevaluate their serum creatinine and GFR 24 to 48 hours after their diagnostic test. You also may want to assess for any claustrophobia or if the patient has any implantable devices, especially if they're undergoing an MRI. These implantable devices may or may not be compatible. So the lumbar puncture is the most definitive diagnosis, and information about the lumbar puncture can be found on page 880 in your textbook. This is the insertion of a spinal needle into the subarachnoid space between the third and fourth lumbar vertebrae. It is used to obtain cerebrospinal fluid pressure readings with a manometer. It's used to obtain central spinal fluid for analysis, check for any spinal blockage that may be caused by a spinal cord lesion, inject contrast medium or air for a diagnostic study, or inject selected drugs. It is contraindicated in clients with signs and symptoms of increased intracranial pressure and skin breakdown or infection or a rash at the site of that spinal needle insertion. So for the nurse's role, we want to position the client in a fetal side-lying position to separate the vertebrae. On your action alert, it emphasizes that it is important that the patient not move during a lumbar puncture. If they're restless or can't cooperate, two people may be needed to help assist with positioning, or a sedative may need to be administered. You want to consider your patient's needs. Post-lumbar puncture or spinal tap, we're going to monitor for any complications of an increased intracranial pressure, such as headache, nausea, vomiting, photophobia, and any change in level of consciousness. And then you want to assess the insertion site for any drainage. The client can have a non-NSAID analgesic prescribed for that headache and inform the provider if there's not any relief obtained. For our nursing interventions and treatments, our anticipated hypothesis is increased intracranial pressure and infection complications, including cerebral infarction, seizures, shock, coma, and death. And our desired outcome is to maintain a normal intracranial pressure range between 10 and 15 mmHg and infection control. We can achieve this by accurate monitoring of their neurologic status, prioritize treatment regimen, and prevent transmission. So refer to box, the Care a Patient with Meningitis box on page 909 in your book. This is prioritize your ABCs, airway, breathing, circulation. We want to perform vital signs and neurological checks every 2 to 4 hours and assess their cranial nerves, especially cranial nerve 3, 4, 7, and 8, and then monitor for any changes in those. Provide adequate pain management. Vascular assessments should be done and monitor for any changes. Administer any medications and IV fluids as prescribed and the patient's response to those medications. Maintain strict eyes and nose and daily weights. Monitor lab values and position the patient carefully to prevent any pressure injuries and provide range of motion at least every 4 hours. You would want to decrease any environmental stimuli, keep the patient on bed rest and head to bed 30 degrees. And then monitor for complications such as increased intracranial pressure, vascular dysfunction, fluid and electrolyte imbalance, seizures, and shock. The earliest change in neurological status is a change in level of consciousness or decreased level of consciousness. Droplet precautions will be placed if the patient has a bacterial meningitis. Broad spectrum antibiotics will be used to treat bacterial meningitis until we get the results of the ground stain and culture, and more specific antibiotic treatment can be prescribed based on that sensitivity. And that specific antibiotic regimen will be continued for 2 weeks. Meds that are used to treat any seizures or and increased intracranial pressure will be like mannitol and any antileptic drugs. And then you want to provide any preventative treatment for those with close contact. Risk factors. It's most commonly a complication of bacterial-based infection in pneumonia, osteomyelitis, endocarditis, sinusitis, otitis media, encephalitis, and brain abscess. It can also any trauma or invasive procedures, and a virus can all be a risk factor for meningitis. So for patient teaching and management prevention, we want to communicate that the most common source of bacterial meningococcal meningitis are Streptococcus pneumonia and Neisseria meningitis. meningococcal meningitis is a medical emergency because it has a high and rapid mortality rate. It's highly contagious, and outbreaks usually occur in high population areas such as college dormitories, military barracks, and crowded living areas. Monitor for any increased intracranial pressure, seizures, cerebral infarction, septic shock, coma, and death. So provide frequent neurological assessment. Refer to your action alert on page 908. This says we should assess for our neurologic status and vital signs at least every 2 to 4 hours. Priority for care is to monitor for early neurologic changes that may indicate intracranial pressure, as we said, such as decreased level of consciousness. The patient is also at risk for seizure activity. We want to prioritize order diagnostics and treatment plan. The CDC recommendation for meningococcal vaccine is for children 11 to 12 years old, and they should receive a booster at age 16. And then we want to provide preventative treatment for those in close contact. And that is the end. Thank you.